All right, thanks for coming. We'll get started. Today we have a great talk, a multidisciplinary approach to eating disorders. And I'll introduce our two great speakers. So Dr. Stephanie Conrad is a pediatric hospitalist here at Phoenix Children. She's the Associate Division Chief of the Division of Hospital Medicine, the Medical Director of the Inpatient Eating Disorder Team. After attending college at Villanova University, she completed medical school at Philadelphia College of Osteopathic Medicine, while also receiving her master's in biomedical sciences with a concentration in immunology. She then went to complete her pediatric residency and chief residency at Penn State Milton S. Hershey Children's Hospital and joined the Division of Hospital Medicine in 2015. She has served as the Creighton School of Medicine Pediatric Clerkship Director since 2017 and has won multiple teaching awards, including Clerkship Director of the Year, 5 Distinguished Educator in Pediatrics Awards, and 3 Golden Apples. Dr. Conrad also serves as the Creighton M4 Specialty Director, a role to prepare and educate fourth-year medical students entering the field of pediatrics. In an effort to improve the quality of stay, length of stay, and patient outcomes, Dr. Conrad, with the help of many others, created an eating disorder pathway, protocol, and inpatient team to better serve the needs of the community. Along with others on her team, she has presented both locally and nationally to spread awareness of diagnosis and medical management of eating disorders. She and her husband, Dr. Jesse Conrad, who is an anesthesiologist, enjoy spending time with their 3 children, Jack, Henry, and Grace. In her free time, she enjoys playing tennis and running. And then Dr. Stacey Halverson is a consultation and liaison psychologist at Phoenix Children's here in Phoenix, obviously. Dr. Halverson graduated from the University of Detroit Mercy, where she completed her Doctor of Philosophy in Clinical Psychology. She completed her internship at the Children's Hospital of Michigan and fellowship at Scottish Rite Hospital for Children in Dallas, Texas. As a pediatric psychologist on the inpatient service, she works with children and adolescents who have been admitted to PCH for a wide variety of medical conditions. Since joining Phoenix Children 6 years ago, she has developed an interest and specialty in working with patients with eating disorders. As the psychologist on the inpatient eating disorder team, Dr. Halverson passionately works with children, adolescents, and young adults who have a known or suspected eating disorder and require medical stabilization and nutritional rehabilitation. All right, that's great. Let's get started.
That's okay. Okay, thanks so much for the introduction. Good morning, everybody. That's not working. There we go. We have nothing to disclose. So this morning, we're going to discuss the types of eating disorders and their medical presentations, as well as the medical management of these eating disorders. We'll also discuss the psychological and psychiatric management and treatment of eating disorders in pediatric patients.
Good morning. So we're going to start out with a brief introduction on the types of eating disorders we'll be talking about today. Some of them are fairly well known or more classic, and others maybe new or newish to you. So anorexia nervosa is the inability to consume adequate nutrition, leading to lower body weight or failure to gain weight. Patients with anorexia nervosa have a fear of gaining weight, a desire to lose weight, or body dysmorphia. And so that leads to disturbance in body perception and intense fear of food and weight gain. Bulimia nervosa is binge eating followed by purging. So purging can take different forms as well. It's not just vomiting. It can be the overuse of laxatives, diuretics, or other supplements, or a non-purging compensatory behavior in order to then release the food after binge eating. There is also, with that condition, still the idea that there is a disproportionate view of body weight or shape. Binge eating disorder is what it sounds like. binge eating, but there is distress and impairment associated with it, as with all of these. Avoidant restrictive food intake disorder, or ARFID, as you'll hear us call it, is the failure to meet your nutritional or energy needs, and leading to a feeding disturbance. There's 3 classic types of ARFID. There's patients who do have sensory issues, and so they restrict their food types due to those sensory texture, things like that. You have your loss of appetite or just loss of desire for food type. In addition, then you have other patients who have a fear. So a fear of vomiting, fear of choking, fear of swallowing, things like that. Maybe there's been an event, maybe there hasn't been, maybe they witnessed it. And you can have hybrids of both of those, all of those, excuse me. And then your kind of catch-all is your other specified feeding disorder or eating disorder. So that would be a purging disorder without binging. That would be atypical anorexia. So anorexia nervosa, but without significant weight loss or being below a normal body weight. You can have bulimia or BED, but with not enough duration or frequency to meet full criteria. Nope. So why are we talking about this today? Eating disorders are serious, potentially life-threatening illnesses that affect individuals throughout their lifespan. They're not pediatric disorders in and of themselves, they're lifelong disorders. They impact both the physical patient, physically and psychologically, and can affect their development. So they're serious. 1 in 7 men and 1 in 5 women will experience an eating disorder by the age of 40. Anorexia nervosa can be a fatal illness. It's a mental illness, but when it attacks the body as well, it can lead to fatality. That can be by suicide because the rates are significantly higher than with other conditions. But we also have to look at things like heart problems, and other abnormalities that Dr. Conrad will get into.
Thank you. Okay, so let's talk about the medical evaluation and management of eating disorders. So when you're out in outpatient world or seeing these patients for a first time, remember to look at their growth chart. So when to be concerned if we're seeing a patient falling off the growth curve, obviously, but also a flattening BMI curve, especially if the patient's younger. Especially with our ARFID kids, we can see height suppression as well as weight suppression. So we're gonna see that flat BMI curve. Just wanted to show you some examples of some of our patients. So this is the classic kind of falling off the growth curve here. We often see just like almost a straight line downward sometimes with their acute weight loss. Now this is an example of a patient with atypical anorexia, which Dr. Halverson alluded to. And I'll talk a little bit more about this in a second, but if you just looked at that growth point there, maybe 60th percentile, you would think that patient is probably fine. But if you look at the overall growth curve, she's had a significant amount of weight loss in a very short time. And we'll actually discuss her medical complications in a little while. So I really just want to discuss that weight suppression predicts illness severity. So 2 examples of this. So we'll have our classic patient with anorexia nervosa, patient 1, a 16-year-old girl who weighed 125 pounds a year ago and comes in at today's visit at 85 pounds. She meets the criteria. It's very obvious on her growth curve. She's 32% suppressed. Is she sick? Of course. But we can't forget about the patient number 2 with atypical anorexia. So 16-year-old girl who maybe, was a little higher on the growth curve than, desired. She came in weighing 250 pounds a year ago and then came in at 120 pounds today, and is 52% weight suppressed. So again, looking at that one weight today, that probably looks okay, but obviously that weight suppression is very concerning and very dangerous. Studies have shown that patients with greater weight suppression have worse ED psychopathology. So we can't just look at the BMI alone. The BMI at a given point in time may be less saliently correlated with poorer outcomes as compared to the amount of weight lost in a certain amount of time or weight suppression. So it's really important when you're talking to these patients to get a really good, I guess what I would call an eating disorder review of systems. So in general, they often report difficulty concentrating and emotional dysregulation, and this has been correlated with low leptin levels. They often have poor sleep. Either they can't fall asleep, they can't stay asleep, or they're so exhausted they just sleep way more than they're used to. They're often very irritable. Most of my patients say, like, I'll pick fights with my siblings all the time and I don't even know why I'm doing it. Like, I feel guilty, I just can't help it. And then they often have headaches as well. From a cardiovascular standpoint, they may complain of chest pain or palpitations. It's oftentimes a marker more of anxiety than something organic, although we'll talk about the cardiac complications in a little while. If they're really malnourished and dehydrated and then working out a lot, this can certainly be due to that as well. Many of our patients come in with bradycardia and hypotension. The bradycardia is typically more pronounced overnight, oftentimes into the 30s and 40s, sometimes lower. It resolves very nicely with nutrition. So oftentimes, even here in the hospital, within 2 to 3 days, we'll see a significant improvement in the bradycardia. Oftentimes they'll, tell us that they're dizzy, especially upon standing, and they may have some syncopal episodes. From a GI perspective, I have constipation and early satiety in red because this is probably like the biggest complaint always, and may have, led to a different workup kind of leading up to the diagnosis of an eating disorder. And then if they have been chronically purging, they often describe reflux and require a PPI for that. From an endocrinology perspective, they may have amenorrhea. They often do. There's no rhyme or reason in terms of like at what weight or what BMI they may lose their period. They often have cold intolerance and hair loss. So in terms of a laboratory evaluation, they rarely have electrolyte disturbances on presentation, which is a really, really important point to remember when you're screening for an eating disorder and, trying to decide how severe they really are. We have a lot of patients who water load so that they'll feel fuller or maybe falsely elevate their weight. Obviously, the sodium may be affected by that. Or we also have a lot of patients who water restrict because it makes them feel full. So obviously, we can see abnormal sodium from that. Hypoglycemia is increasingly being understood as an increased risk for morbidity and mortality. So we really need to keep a close eye on these patients with a glucose less than 70 when they're presenting. We'll talk a little bit more about that later too. We'll see alkalosis with purging. We certainly can see an AKI with dehydration. And then we do see transaminitis. So I have an example. We'll see the LFTs into the hundreds. We typically, once it's kind of like over 1,000, obviously work that up. But we do know that we can see elevated LFTs and a high bilirubinemia. So this is due to liver autophagy, and it's going to take weeks of nutritional rehabilitation to recover. So we don't typically repeat those here in the hospital and recommend not repeating at least for about 6 weeks. It's also important to note that these patients have a preserved albumin level. So we don't see a low albumin as you would potentially think with a malnourished patient. When we get a CBC, we may see iron deficiency anemia. We can see bone marrow suppression. Oftentimes it's going to be leukopenia and neutropenia, again, along with the liver. This can take about 6 weeks or so to recover. So again, not something that we trend acutely. Other labs that can be important, obviously nutritional labs. Here we get a vitamin D and zinc. We automatically put our patients on thiamine, but that's something to consider as well. We often on new diagnosis will get thyroid labs. Their thyroid labs are either normal or will show us a euthyroid sick pattern. So a low T3, either a normal or a low 3T4 with a normal TSH. Obviously getting a celiac panel on presentation would be appropriate. 50% of patients with anorexia nervosa have high cholesterol. That's not something that I check here because I worry about my patients hearing that they have high cholesterol and twisting that. But they are known to have a high level of HDL. This is thought to be from exercise and weight loss. They may have a mildly elevated LDL. Studies are showing that this may be related to abnormalities in estrogen, thyroid hormone, and glucocorticoids, but no treatment is obviously recommended. So I just want to go through a few cases here. So this patient of ours, this was a 17-year-old female who presented from her PCP's office for severe anorexia nervosa. You can see here, I didn't have tons of growth points, but you can see this significant weight suppression here. So in 18 months, she went from about 130 pounds to 57 pounds with 56% weight suppression. She basically had all of the telltale signs on physical exam. So when we look at her labs here, you can see that she came in with hypoglycemia. And she did have some postprandial hypoglycemia in her first few days with us. So what happens in these patients is because they're not used to seeing a lot of food, they have a very significant insulin release when they do see food. So we actually worry a lot about their postprandial glucoses. So that's why if we're worried, we check 30 minutes after a meal because we can see these glucoses drop tremendously and oftentimes have to give juice or gel for that. This patient also had a high bilirubin and AST, ALT, as you'll see here, consistent with liver autophagy. She also had bone marrow suppression, and that's the reason she was actually sent in by her PCP, because he was worried about this neutropenia. Not something that we typically tell families, especially if we're trying to get their buy-in. This family was not really concerned about their daughter's health. So we kind of hung on to, you are at risk of increased infection, but in general, we really don't see an increased risk of infection in these patients. That's more adult world, very, very chronic anorexia. This patient also had a pericardial effusion. So I often don't get echoes, but she was such a low body weight and I was really trying to convince family that she needed treatment. So I did get this echo. It did show a pericardial effusion. So this can be an early sign of anorexia. The etiology is unclear. Roughly 25% of patients with anorexia have pericardial effusions. They are asymptomatic. There's only one case described with tamponade. Obviously, if you're seeing signs that make you worry about large pleural effusion, you should get an echo, but otherwise just know that it's expected to improve with weight restoration and does not need any intervention. So just to discuss some other cardiac complications with eating disorders, this is all thought to be related to cardiac vagal hyperactivity. So like I mentioned earlier, bradycardia, it may be the most common presenting sign of anorexia. They may often tell you, well, I'm in good shape, I'm an athlete, this is to be expected. But unlike athletes who we don't see a significant increase in heart rate when they're active, these patients become tachycardic even with minimal exertion. Heart rate can decrease even into the 20s. Pacing, even temporary, is very rarely indicated, and it improves, like I said, fairly quickly with nutrition. We often see orthostatic changes, and these may persist until significant weight restoration is achieved. We also monitor for QTc prolongation. This is really typically due to electrolyte disturbances or perhaps other medications that they're on. We typically don't see this just with malnutrition. We can also see structural abnormalities. So we do know that they have a reduction in chamber dimensions. This can lead to annular laxity and subsequent mitral valve prolapse. We also know that this is self-limited, that improves with weight restoration. We can see a reduction in left ventricular myocardial mass. Obviously, this can affect left ventricular function. Studies do show that they have myofibril atrophy, which can decrease contractile force and cardiac output. And then finally, some studies suggest myocardial fibrosis, which would obviously put our patients at increased risk for malignant arrhythmias. Here at PCH, and this is really standard across the country, inpatient cardiac monitoring is for a prolonged QTc and arrhythmia or bradycardia less than 45. And like I said, usually with a few days of the initiation of nutritional rehabilitation, we're able to get them off telemetry. So moving on to patient B, this was a 16-year-old male with a history of several years of anorexia nervosa. He had come to us in October of 2022 weighing 42 kilos, and then was admitted March of 23 weighing 33 kilos. He endorsed restricting but denied purging or the use of laxatives up and down, but his labs did not lie. And he came in multiple times and we saw this potassium be consistently low. So he came in with 2.6. We also looked for an alkalosis and purging. So he had a bicarb 35. Typically, we say over 30, you need to suspect purging, and then greater than 36, you're pretty much, you've solidified that diagnosis. He also consistently came in with a creatinine, obviously consistent with an AKI. And these are just his labs here showing that despite multiple replacements, he had persistent hypokalemia and an AKI with an alkalosis for quite some time. So metabolic alkalosis is the most common acid-base disturbance seen in individuals who purge. Both vomiting and diuretics can create a contraction alkalosis secondary to the loss of sodium chloride, which results in an intravascular depletion. If we have a patient using laxatives, acutely it can cause a non-GAP metabolic acidosis, but chronic use can lead to a mild metabolic alkalosis with hypokalemia. We do try to avoid fluids in these patients, even if they come in significantly dry, or we're at least judicious in our use. So if we have a patient who is severely or chronically purging, the restoration of aldosterone can take weeks. And if we give too much fluid, we can see significant edema and acute weight gain when those aldosterone levels are high. And like I said, an elevated bicarb is highly suggestive of self-induced vomiting. On physical exam with these patients who are purging, we can see dental erosion, increased sensitivity to cold or hot temperatures, and possibly increasing the rate of developing caries. We can see usually bilateral and painless parotid gland swelling. The swelling often occurs several days after abrupt cessation of purging in somebody who's been chronically purging. I think we all learned about the Russell's sign in med school, where you can, see the skin abrasions or calluses on the knuckles from self-induced purging. Although when patients are chronically purging, they often don't need any help to do that. So, that's not necessarily always there. From the force of vomiting, we can see periorbital petechiae or subconjunctival hemorrhages, and then angular chelosis from all of the gastric acid coming up. In terms of their laboratory evaluation, if they have a concomitant hypokalemia, that can kind of further solidify your diagnosis, but we don't always see a low potassium in these patients. Again, we'll see an alkalosis. And we can see elevated serum amylase. This is salivary based. So if you really were trying to prove that you had a patient who was purging, you could potentially follow up with a lipase. And finally, we have patient C here. I showed you her growth curve earlier. So she came in with atypical anorexia. So if we look at that one single point, we may think a BMI of 18.8 is okay. She looks like she's at a healthy weight, but she had lost a significant amount of weight very quickly. She was actually brought in by an outside cardiologist for a pericardial effusion and decreased left ventricular function. She experienced significant early refeeding and edema with her nutritional rehabilitation. So I wanted to touch on that real quickly. So in early refeeding, we get an exuberant GLP release and excessive insulin secretion in response to carbohydrates. So if you remember, the insulin's normal effect on the kidney is to cause salt and water retention and edema. So we do see edema in our patients when they're refeeding from time to time. It's not consistent. It's typically mild. Hers was actually a little bit more significant. It typically goes away in a few weeks. We just recommend leg elevation. And we do avoid diuretics. It can actually worsen the edema via aldosterone. And again, I just want to stress, despite a quote unquote normal BMI, this patient was very sick and showed significant refeeding syndrome. So to touch a little bit more on refeeding syndrome, the rate of a low phosphorus in adolescence is 14%. Highest risk patients are a median BMI of less than 70% or a BMI of less than 16. Velocity of recent weight loss, regardless of BMI, is a very strong individual predictor. Low abnormal electrolytes or hypoglycemia before refeeding, and then a history of diuretic, laxative, or insulin misuse. And again, I mentioned the glucose earlier, but that's a really important one to watch. So going back to post-World War II, we saw the effects of refeeding syndrome, certainly in the Holocaust survivors. We saw the effects of nutrition on their emotional state. But when carbohydrates are given too rapidly during a malnourished or emaciated state, severe damage can occur Many of these patients enrolled in the study had significant edema and other health effects from refeeding. Currently, I won't go into the nutrition details, but we typically start around 1,500 calories a day. It used to be much slower. Studies are looking at higher starting points currently. When they're really young, we will start lower, and we typically increase by about 200 to 300 kcals a day. They are at highest risk of refeeding in the first 2 weeks. I typically say it's usually around day 3 to 4-ish. But we recently just had a patient who didn't go into refeeding until day 8. So luckily she was here. And then in that case, sometimes we do have to decrease their calories and of course, give them electrolyte supplementation to decrease the refeeding process. In terms of psychopharmacology, food is really the best treatment, especially when they come in severely malnourished. Landmark studies have shown decreased levels of norepi, dopamine, and serotonin. So a lot of times people are apt to immediately start an SSRI that may not necessarily be appropriate. Obviously, if you have comorbidities like severe depression, anxiety, OCD that are driving the eating disorder, 100% we need to treat that. But a lot of times we need to start with nutritional rehabilitation. And then once they're a little bit more weight restored, then we can move on to psychotropic medications. And I'm sorry, this is like hiding it there. I don't know where to put that. So oftentimes we won't start medications until they're around 85% of their goal weight. That being said, fluoxetine and other medications are FDA approved for bulimia nervosa, and they have been shown to improve the binge purge frequency in the absence of a mood disorder. Just a few other notes before I hand it back over to Dr. Halverson in terms of eating disorder management. We can see hypermetabolism following a starvation state. This may happen here, this may happen later. But we'll see weight loss despite eating goal calories, and we'll have to ramp up those calories, sometimes to a pretty significant goal. They will mostly describe tachycardia and night sweats, going through like multiple pairs of pajamas and sheets a night as their metabolism is really revved up. We continue to see gastroparesis for a while, which is a really difficult thing in these patients. They have very early satiety. So oftentimes, we'll recommend smaller, more calorically dense meals. Typically, across the country, the average meal plan is going to be 3 meals and 3 snacks a day, just so they're not seeing really large volumes that they can't handle. And then many of our patients suffer from constipation, and it may take a while for them to get back on a regular schedule. So I always tell people, don't be afraid to give Miralax. Obviously, we don't want to make them dependent on Miralax long-term, but they're miserable. So you need to just help them out. In terms of low bone mineral density, there is no current evidence to support the use of oral estrogen preparations, including OCPs, for the treatment of low bone density in a low weight patient with amenorrhea. Weight restoration and resumption of menses are treatments of choice. So the only role of birth control in these patients is if they are sexually active, because the absence of their period is not protective. Otherwise, weight restoration is really the gold standard. In terms of DEXA screening, in the adult world, the guidelines are much clearer. But in children and adolescents, the fracture risk is increased by 60% after 1 year of anorexia. So the risk in screening should be discussed with patients and parents. And it's also very important to remember that males often get missed in the screening. Again, the gold standard for bone density loss is weight restoration, and this may include menses restoration in females. This is based on the 2015 SAHM guidelines. And so I just wanted to briefly kind of show you the things that would get a patient admitted to an inpatient facility like ours or many others across the country. Obviously, severe malnutrition, electrolyte disturbances, physiologic instability, but a lot of times it's acute PO refusal with not having a good plan or a good outpatient team, and they need further support. And I will hand this over.
Okay, so we're going to talk a little bit about the psychological evaluation and management of eating disorders, which may be a little less familiar to you than some of all of those terms that Dr. Conrad just used that I only know what half of them mean. So, uh, only the clicker works. Sorry. Thank you. Okay, great. Everyone needed a break, right? Okay, so when we see patients in the pediatric hospital setting, we're typically seeing certain diagnoses. So we're seeing anorexia nervosa, we're seeing avoidant restrictive food intake disorder, and we're seeing maybe patients that don't fall neatly into that category. So maybe they're falling into the other specified feeding or eating disorder category. Binge eating disorder and bulimia nervosa are less present presentations in the pediatric setting. One, because they do not typically have significant or abnormal weight loss or have significantly low percentage of ideal body weight or BMI. So they're not detected, not to say that they don't need treatment. So our message to everyone always, and every time we've talked to any group, is to say, just because a patient is not underweight does not mean they do not have an eating disorder. So you want to be asking those questions about their eating habits, and we'll go into that in a little bit. There are other presentations for eating disorders, and so these are related. They're not DSM per se diagnoses, excuse me, but they're things to be looking for. So orthorexia is the excessive preoccupation with healthy foods. So cutting out sugars, carbs, processed foods, packaged foods, things like that. Only organic, things like that. And it can get so restrictive that it gets into the place of an ARFID or anorexia. What we used to call diabulimia, or it's now called eating disorder DM type 1, is the purposeful restriction of insulin in a patient who has type 1 diabetes in order to lose weight. So that's something we need to be looking for when we're seeing these patients here in the hospital. Multiple DKAs, patients, not even multiple, single DKAs, we need to be asking about their use of insulin, and also if there is any purpose behind it. We certainly see other comorbid conditions that can contribute to eating disorders or eating disorder behaviors, disordered eating, if you will. Autism spectrum disorder comes to mind. As we know, patients on the spectrum can be very rigid and repetitive, and then therefore restrictive in their eating habits. OCD comes to mind as well. So we want to be screening for these other conditions and be keeping those in mind when we see these diagnoses pop up on their diagnostic list. We're getting a lot more research now, finally, on the impact of gender dysphoria on transgender patients, and how they may use different eating behaviors in order to change their body shape to be more of the desired or the more authentic gender that they feel they are, or orientation. And so I saw one stat that said 15% of transgender patients have an eating disorder. I would gather that that's probably an area of ongoing research that we just need more data on, and we just haven't captured that population enough yet in order to really be able to put a number on it. So when we're talking about evaluation of eating disorders, we're looking at a number of things. And so we, of course, want to ask about the course of the illness. So how long has this been going on? When did it start? Were there any triggers? There may not be. Sometimes there are clear triggers. Bullying, unfortunately, a pediatrician saying you're overweight, you need to lose weight, different things, bullying at school, just peer influence, things like that. Social media is not our friend when it comes to eating disorders. So asking about the course of the illness, when did it start? How long has it been going on? And how has it changed over time, if at all? Restricting behaviors, of course, we're going to ask about. So are we counting calories? Are we dieting? Are we skipping meals? Is there fear foods or safe foods, especially with our patients with ARFID? And then hiding and throwing food away is common as well. With our patients here in the hospital, part of the reason why we have a sitter in the room when we're treating an acute eating disorder is to make sure that the patients aren't hiding or throwing away their food in an effort to restrict, because we need to kind of know what's going in the body, for sure. Purging behaviors. When we say purging, most of us think of vomiting, and I did up until, I guess, recently too. But it can also mean the use of diuretics, laxatives, diet pills, stimulants. There's a whole row at GNC of things you can use to speed up your metabolism or, change how your body metabolizes the food. And so excessive exercise is also a question. We don't get into it too much in this presentation, but athletes are prone to eating disorders. You think of wrestlers who need to drop body weight. You think of gymnasts, cheerleaders, flyers, ballerina dancers, things like that. So just because someone plays a specific sport obviously does not mean they have an eating disorder, but you want to be asking those questions to understand if the exercise or sports activity has become excessive relative to the amount of intake. Binging behaviors, you ask questions about, do they feel like they eat too fast? Do they get uncomfortably full? Is it like Thanksgiving, twice a week? Eating large amounts, even when they're not hungry, eating alone or in secret. And then kind of the guilt that goes along with eating can be pretty, guilt and or shame can be pretty profound. And if you ask about it, they'll typically tell you. So we just need to be asking those questions. With binging, you're asking, of course, about frequency and timing. And then body image. We see things like patients weighing themselves, many times a day, having a scale in their room or sneaking into their parents' room to use their parents' scale. Mirror checking, measuring, all sorts of different kind of ways of keeping an eye on that. And so you'll have patients that will tell you that they have a fear of gaining weight, and they have distorted thoughts about their body. So those are the things that we're really thinking about. Those are those key topic areas when it comes to eating disorders. Some of us are more comfortable than others about talking about eating disorders with patients. And so if we're asking you to do that more, we want to, also let you know that there are some tools out there that can be downloaded and used and administered. I won't get into them too much. I don't use them personally very often because I know the questions to ask because that's my job. But for people that don't do this every day, there are tools out there available for your use that you can use as screeners that can point you in the right direction. The SCOFF is kind of the oldest. It's 5 questions. And one of them asks something about if you've lost weight more than a stone, which apparently is 14 pounds. I don't know if anyone in this room is old enough to know that, but so the questions are a little more old school, but they will still get it, the info you need to start pointing you in the direction. So when it comes to evidence-based treatment for eating disorders, we want to talk about a couple different areas. And so this is kind of more, my realm than the medical realm. And so when it comes to the first line treatment is family-based therapy. And that's if and when a patient is ready to really do outpatient work. So in the acute setting and the medical setting, it's not necessarily appropriate to start FBT. But once you get to that point of stability, that is the gold standard. And so the first studies for family therapy were conducted at the Maudsley Hospital in London. And then subsequently in the United States, they've kind of modified some of that. At the University of Chicago, Stanford were also key in making some of those modifications to what we call FPT. And the 5 tenets of FPT are that the therapist holds an agnostic view of the cause of the illness. The therapist takes a non-authoritarian stance in treatment. Parents are empowered to bring recovery for their child, so they're part of the process. It's not an individual problem. It's not individual therapy. The caregivers, parents, grandparents, whomever they are involved in the process. The eating disorder is separated from the patient and externalized, at least in the beginning, to give the patient the freedom to kind of understand that. And that can kind of be fused back together once you've gone through treatment. And then FPT utilizes a pragmatic, approach to treatment. So the focus is on the here and now. What are we doing today? What can we fix today? What can we do better today? And then we'll work on tomorrow. Cognitive behavioral therapy, probably a little more known to most of us, is the form of treatment where we're working on the cognitions and then behaviors that are associated, in this case, with eating disorders. So we are looking at the cognitions that are not helpful, that are distorted, and how to kind of change those, how to confront those. We're looking at learned patterns of unhelpful behaviors or disruptive behaviors that are causing distress and impairment. And the tenet is that you can learn coping behaviors that will improve your life. You're trying to recognize those cognitive distortions, and then you move towards family involvement when it's appropriate. So CBT can be done on the individual level, but having a family component to it, especially with an eating disorder, is going to be important. DBT, dialectical behavioral therapy, is another form of therapy. It's called, in our world, it's called part of the third wave of therapies. And it's a modified version of CBT, where there's an emphasis on the experiences one has to work on themselves. And so the 4 skill sets that you work on with DBT are acceptance-oriented skills, such as mindfulness and distress tolerance, and then change-oriented skills, such as emotional regulation and interpersonal effectiveness. We work often with the first set in the hospital setting, with distress tolerance. We see that a lot, and so we work on that a lot. Child life is our friend. And so finding ways to kind of reduce that emotional level is really important, especially when it comes around time to feeding and eating. When it comes to different types of treatment and lengths of stay, we'll get into that in a second, but you're certainly, when you're talking to families, if you think they require an outpatient level of care, you're giving them at least an estimate of 6 months. This is not an easy process. It didn't happen overnight. It's not going to be fixed overnight. So for our eating disorder levels of care, we think about, kind of the highest level is inpatient. That's equivalent to our institution. So you're getting medical care, and that's kind of the primary component: medical stabilization and nutritional rehabilitation. Residential, I'll go into these a little bit more. Is kind of what it sounds like. You stay there and you receive treatment. PHP is a partial hospitalization, and that's what we used to call a day program. So it's almost like going to school, but it's treatment. Intensive outpatient programs are going to be a little bit step up from kind of that once a week therapy, once a week dietitian that I'll get into in just a second. Over the course of the last 3-4 years, there's been the development of virtual intensive outpatient programs, because during the pandemic, people realized that there's people that need access to these levels of care when they couldn't get it. And so we do now have virtual intensive outpatient programs. For most people, in-person treatment is ideal, but this does exist. And so it can be a very useful outlet for patients that simply don't have either transportation, they're more rural, for any number of reasons, that they don't have access to that in-person treatment. So residential treatment, like I said, they stay at their residence. They receive treatment daily. It's a multidisciplinary team of providers. The components include individual therapy, group therapy, nutritional counseling and education, meal exposure therapy, and then there's often some added therapies like expressive arts or art therapy, things like that, equine therapy. And so they're really trying, it's a very programmed day of trying to provide that support to the patient from a multidisciplinary approach. PHPs are partial hospitalization programs. Again, what we used to call them therapeutic day programs. It's where the patient goes during the day and then goes home at night. So they don't stay there. So an example might be from Monday through Friday from 9 to 3 p.m. You're doing meal exposures, medication management can still be done there. You're using those evidence-based treatments, FBT, DBT, CBT, and they're using other holistic therapies sometimes. So that may be massage, that may be acupuncture, that may be different things that they're trying to look at, the whole person if they're able to do that in that setting. The patient can remain local and return home in the evening. That's key for some of our younger patients, right? So the idea of taking an 11-year-old and putting them in a residential facility is really hard. Or a 12-year-old. And so if we have one such program in Arizona, a PHP, and it's really been extremely useful for our patients because it still allows for that family connection and being able to go home and sleep in your own bed. Intensive outpatient programs, kind of again what they sound like. Outpatient programs where the patient remains at home. They often can still go to school if that is what they choose to do. And then they would go to an afternoon program, maybe 3 to 4 days per week for about 3 hours. There you're going to have group therapy, meal exposures. You'll do dinner and a snack usually. And then you have access to a mental health therapist, a dietitian, and weight checks. Outpatient services are, what we sometimes do when patients leave our institution, if we feel like they're stable enough to do that. And so that involves making sure that we have an outpatient pediatrician. That often involves a doc-to-doc or a conversation with Dr. Conrad or the attending physician ahead of time with that pediatrician to make sure they understand the patient's current status and what their needs are. Setting them up with a dietitian, of course, in order to continue to move along that meal plan and adjust as needed. A therapist or a psychologist who's trained in eating disorders, ideally, if not, trained in maybe one of the comorbid conditions that goes along with it. So anxiety, OCD, things like that. And then a psychiatrist if needed, if medications are on board. So just a couple of additional resources. There are places where you can go to get more information. And so, IADEP is an organization that we belong to. But then the National Eating Disorder Association has a ton of information as well. And it's written in a way that's understandable. So it can be very helpful. Eating Recovery Center is a facility that has multiple locations, but they're very, very set on education. So I personally do a ton of free CEs on their website because they do a lot of information that's, again, covering a number of topics, sometimes adult, but oftentimes pediatric. And so it's a good site to look at. The purple book, as it's called. I knew I was gonna laugh.
It's a really great resource online for people who aren't really in the thick of eating disorders, but have quick questions in terms of management. It's a really quick, easy read by the Medical Standards Committee of AET. And then that book over there, Sick Enough, it's a really great medical book, outlining different cases for eating disorders. It's a really easy, quick read, just using case examples. So I always highly recommend that for people who are interested.
And then I might have talked a little faster than I wanted to, but we would open it up for questions at this time.
I'm an outpatient pediatrician, and often I see patients getting discharged from the hospital to maybe an infant outpatient program. Do you know if there's a resource if patients don't meet the inpatient criteria for outpatient pediatricians that find the partial hospitalization programs and intensive outpatient programs instead of like?
It's a relatively short list. So I don't know what would be the best, you could certainly reach out to us and we can tell you it. I can list it off. I might know the addresses of some of them off the top of my head. So it's a pretty short list. In terms of state by state, we're actually luckier than most. But that's definitely a list that we could share with you.
And then is there like a criteria or an insurance process, you know, about that?
Yep.
I mean, for anybody outpatient, if you think that a patient needs to come in for medical stabilization, or if you just want to chat about the patient, it's really a medical admission. So patients usually don't have to go through an insurance process. We just do like a direct admission or something like that. But a lot of times pediatricians will just call or email us and say, we have this patient, can we run it by you? And we just kind of chat and figure out what level of care might be appropriate too.
There's a question in the Zoom. What about the role of appetite stimulant medications such as insulin?
Yeah, that's a great question. I think every center does it a little bit differently. We don't use a lot of it here. When I have patients with really pronounced early satiety, I may try something like cyproheptadine, and I typically don't feel like it helps. But like ERC is very aggressive with that. So I think it really just depends on people's training and their style.
And I had a question about kind of like the cardiac complications or even bone density. Does age of diagnosis or age of like starting of treatment kind of matter in terms of like their future risk for?
Yeah.
arrhythmias or bone density?
I mean, so in terms of just really anything related to eating disorders, the duration of illness is really predictive of long-term effects. So the goal is always to get treatment going as early as possible. I will also add to that medication question. A lot of our patients are really afraid that any medication will make them fat. So we have patients refusing vitamin D, multivitamins, like anything. So they're very, very aware of medications, psych medications, anything else that may improve their appetite or cause them to gain weight.
Oh, and thanks for the talk, guys. That's really terrific. A question kind of long term for these kiddos, they're so young sometimes. Does this set them up for a lifelong experience with this? And can we treat this in these younger kids? Can we fix this problem for them? I know you said it takes 6 to 12 months, sort of an issue, but if they get appropriate care, can this go away? Can they solve this problem, or is this a lifelong thing for these kids?
The real truth answer is it's a lifelong thing. Do we see patients with certain types of eating disorders resolve? Absolutely. Do we see ARFID resolve? Yes. Can we get from those 5 preferred foods to 10 to 15 to 20, and then, you know, it's no longer causing distress or impairment, you know, and they can live a normal life? Absolutely. Anorexia and bulimia are known to be, anorexia in particular is known to be more of a challenge and a lifelong process. And so your relationship with food and your body can be very hard to change. But you can see certainly patients, there's famous patients, that you can again find on social media, who have recovered. And so it's possible. So maybe they still have distorted thinking, distorted, thinking about their body sometimes, or about food, but they're at a healthy weight, and they're able to function, and have a decent quality of life. So yes and no is my answer to that. I think the other thing real quick, if I just wanted to mention, Dr. Conrad mentioned that patients are afraid often of things that you'd be surprised of, any medication, a multivitamin, things like that. They often start to restrict water as well. And they know logically that water has no calories, but we see that very often now. I think that's almost newer to me, but so it's something to definitely keep an eye on as well. You wouldn't think about that. You think it's just water. On the other hand, you see patients that water load. So they drink tons of water in order to then get that feeling of fullness, so then they eat less. So looking at hydration is really key. And I don't know if we've quite highlighted that, but something to keep an eye on.
And I'll add to like long-term prognosis. A lot of times we'll talk to patients or families, parents are often asking that question, like 100% they can get to the point where they're leading a healthy, normal life, but they're going to have to keep an eye on themselves, right? Like they have a significant life event or something like that. So just kind of always being aware of where they were and just keeping an eye on things moving forward.
And then maybe a final couple of questions. They're about SMA syndrome specifically. So are there any special approaches when a patient has been found to have SMA syndrome from the weight loss and another attendee asks, what about the continued medical studies despite likely knowing the diagnosis is anorexia, like evaluating for SMA?
So we love our GI colleagues very much, but we hate SMA syndrome. So I think any of my patients, if they receive imaging, would probably show SMA syndrome. And I have had patients, but they're not vomiting and they're able to tolerate their feeds just fine. So I'll cautiously say that, you know, if we have a patient with a known eating disorder who's not vomiting, we would not pursue an SMA workup. We're going to provide nutritional rehabilitation and hopefully recover that fat pad anyway. Certainly, if you have a patient who's vomiting and not able to keep things down, like we're not going to ignore the obstruction. But we do expect potentially pain or certainly discomfort with eating, early satiety. So those things would not prompt us to work up SMA.
Thanks so much.
Thank you.
Sorry.